Right, okay, so this is put together last minute because of this one. Who actually has bailed us out, so she's done a good lecture. So what I've tried to do is I've got a quick look through your ACT conditions and the sort of things that I imagine you probably won't have done much on, but that are possible to still kind of come up. How are you all feeling for your exams, given the fact that they're in, 14 days and 21 days? Yeah? It's good. Because you shouldn't feel like, oh, it didn't work. Anyway, there was meant to be audio there. But no, you'll be fine. You already know all the stuff. You'll have gone through most of it. It's just a case of making sure you get it down now. You'll have put the work in, even if you've only been working the last few months. Most of the stuff you're going to get tested on have been drilled into you over the few years. You just won't have realised it. So a quick bit on the exam format, which I'm just going to skip straight over because Shenna did it. And then a few of the ACT conditions over these, and then any questions you want to ask about anything at the end. So we'll skip over that because that's probably wrong. But yeah, do any of you know that list? Because it's pretty extensive, to be fair, isn't it? So that's basically the ACT conditions. Now, there's no hope in hell of me going through all of them at all. So what I've done is I've highlighted a few there in red that we're just going to quickly go over. Some of them we've already covered because Shenna's mentioned them as well. But these are the sort of ones that even if they don't come up in your OSCE, which, I mean, some of these will do, certainly, but they're the things you're going to worry about and see when you're working as an FY1. So I thought we'd go over them quickly. So, acute left ventricular failure. What sort of symptoms do you get with that? Just shout them out. Quick fire. Can't be wrong. Say again? Dyspnea, yeah. Pink frothy sputum. Come on. Chest pain, yeah, you can do. Depends. You can have an MI, which leads to it. You going into acute LVF, so you can get chest pain. Yeah, I'll give you that. What sort of things? If you're the FY1 that's been asked to go and see a patient, what things would you be looking for in the notes that might lead you to this? Recent MI, yeah. Any kind of history of ischemic heart disease. Very few people go into acute LVF without having a history of kind of cardiac problems. So the most common diagnosis, I saw it within my first 2 weeks of care of the elderly, and it's flash LVF, and it's in patients that have long-standing ischemic heart disease, and then they get like a urinary tract infection, which just throws them a bit off balance, and they get massive pulmonary edema in like a day, and you're thinking, shit. And it's all a bit scary. But yeah, your symptoms, so shortness of breath, ornithopnea, pink frothy sputum, raised JVP, they're fine crackles on auscultation, and your history is the one that gives you kind of the confidence to just go for it. Investigations, what would you do? Chest x-ray is going to give you your diagnosis, so you book that straight away, you get a mobile chest x-ray and you get that sent off. Then what have you got to do there and then with this patient? Set him up, yeah. Oxygenate. And other investigations you think? ECG, yeah. So you're doing ECG, and the main reason you're doing an ECG is because although they've had a history of ischemic heart disease, you want to rule out an MI to have caused it in that episode. Generally in elderly patients, they don't have chest pain, or they always have chest pain, and so just do an ECG because it'll tell you either way. So ABG is the other big important one because you want to know what their respiratory is like, if they're acidotic or if they're hypoxic. ECG, chest x-ray. And then I've queried the echocardiogram because it's something that you'd need to be thinking about, but in the immediate dealing of that situation, you don't want to worry about it. That's kind of post getting them out of the woods with it. And how do you treat it? So we mentioned you start on oxygen, you sit them up, start them on oxygen. GTN, yeah. Say again? Morphine, yeah, gives them pain relief. Well, yeah, so yeah, and what does that do? Gets rid of the water. So they excrete the water, they lose the water from the lungs. It makes the breathing a lot easier. How much would you give? 40 milligram. How would you give it? IV. And would you wait for the chest x-ray? No. If you think it's acute LVF, give the furosemide and worry about the consequences later. because if you've got it right, the situation's only going to get better. If you've got it wrong and you're waiting for the chest X-ray, you can't say how long that's going to be, and the patient's just going to get a lot worse. So give the furosemide. And if you're worried that you might have got the diagnosis wrong, speak to the cardiology reg on the phone, and they'll come. So oxygen nitrites, furosemide, morphine, and the cardiology review. If you're worried about this patient, just speaking to them cardiology on the phone will help you, because they'll tell you what to do. Sometimes you need to set up a nitrate infusion, but most of the nurses on the wards, unless you're on a cardiac ward, won't be able to do it. So the cardiology reg will say that, and at which point you go, it's not going to be able to happen on this ward, and they go, yeah, sorry, I knew that, we'll take them over. At which point you just need to make sure they're alive until the cardiology reg comes to see them and takes them away. And that's what happened on my first week of care of the elderly, and I had 2 of them at the same time, which was a nightmare. But the cardiology reg was really good and just basically came up and took them down. So that's that. What does this show? I'm going to look myself. Can't remember. Come on, diagnosis? Yeah, second degree heart block. There's random ECGs. I didn't want to put them all in order after the things they follow, because you'd guess just on what we're talking about. So there's going to be random ECGs throughout. This one. Go up. Go on, you're all thinking it because you haven't come up with a diagnosis, so yeah. So if there's nothing jumping out at you, go for it. Say normal. We got shown a normal chest X-ray in the patient that had a PE. If you're not thinking about a PE, that'd be you could spend ages looking at that chest X-ray, because you could be looking for something that's not there. And so don't. If you don't see anything, gamble, hedge your bets. You're probably going to be right, and it will be normal. This one. Yeah. And this. And I've shown it in this way for a reason. S1Q3T3, yeah. So forget what S1Q3T3 looks like for a minute. It doesn't matter. If they show you leads 1 and leads 3, and they're the only leads you get, it's S1Q3T3. Just put it down. It doesn't matter. And because they literally in our slideshow gave us that slide just like that, and I didn't get the diagnosis because I was too busy thinking, what the fuck have they shown us leads 1 and 3 for? And as soon as I walked out, the penny dropped, and I was like, Jesus. So if you get leads 1 and leads 3, it's S1Q3T3, all right? And it's a PE, straight off. If you want to know, it's S1 is this bit here that actually goes down. On a normal ECG, it doesn't. And then the Q3 is this little flick here. Is that actually coming up? Yeah, it is. So that's that bit there, and it's then an inverted T wave. So that's what S1Q3T3 is. It's really rare, but again, I saw it in MAU in Bradford, because if you see weird and wonderful things, you're probably in Bradford. And I've actually seen that ECG. So it does happen. And that's the same slide that Shenna had up, and it just identified. If you Google it, it'll come up with that picture. Saying complete heart block, all right? What are the symptoms? Syncope, yeah. Any more? Yeah. Common one. If you're short of breath most of the time and you're collapsing every now and then, what you're going to feel like? Dizzy, tired, yeah. So the other thing is you might not have anything. Syncope. What type of syncope things? Can you think of an eponymous syndrome? Yeah, Stokes-Adams attacks. That's something that might come up in your multiple choice things. So that's what you can get with that. Investigations? Yeah, pretty straightforward. And a 24-hour ECG, because you want to know what it's like. It might just be a kind of a paroxysmal. It's often not, but you probably want to know about that. And then how do you treat it? Yeah, permanent pacemaker. You wouldn't do anything, so it's just permanent pacemaker. What's this ECG? What's that? Who spoke? I heard it. Hyperkalaemia, yeah. So why do you think it's hyperkalaemia? Tall tented T waves, yeah. So that's your barn door hyperkalaemia. The reason it's difficult is because it looks so abnormal. So if you think the ECG just looks really weird, make sure you spot these. So that's actually the QRS, but the tall tented T wave is that there. It's oh, hold on, have I got that wrong? Oh, hold on. Yeah, no, it's. I thought it was. Yeah, so it can be, and you would see it in often, but not once it gets. So this is kind of, you never want to see this ECG because you want to have seen it earlier than this. If you need to give calcium gluconate like straight away in this patient, and you give that because this is going to go into an arrhythmia. So it progresses, and you're right. You generally, your first kind of sign is just the T wave tenting. But when that progresses, you're entering into kind of arrhythmogenic rhythms, and that's what that kind of this looks like. So if you get that ECG and you've got a recent U&Es, or you've done a VBG or an ABG, and you've got a high potassium, you need to treat it like now. So I've just mentioned what your first treatment is. How would you do? What go? Calcium gluconate. How much? Yeah. Then what? Yeah, 50 mils, 50% dextrose, and make sure you do that. So in Bradford recently, there's been somebody who's gone to treat hyperkalaemia, has given the calcium gluconate, has given the Act Rapid, but didn't give the dextrose, corrected the potassium, but the patient ended up on ICU because of a hypoglycemic coma, and that's happened, and they've ended up having to basically retrain. It wasn't this year, it was last year, and that. So, yeah, so that's cool about jumping from the frying pan into the fire, and you make sure you get the dextrose on. And salbutamol nebs will help. Forget about calcium resonium. I know they get taught it, but in this situation, it's not going to help you so it depends completely on hospitals. Some people set up a syringe driver on the Act Rapid 10 units that just constantly goes in, and through the same, because you have a drip with two kind of tubes on, and they'll have the 50 mils, 50% up at the same time, just infusing into the same cannula, but separately. And that allows you to tinker with things, but it doesn't really matter as long as you write it up the same. So you go 50 mils, 50%, and then in your additives part of your fluid chart, it's 10 units of Act Rapid, and then that way it doesn't get forgotten, which is why most people do it like that. So yeah, that's when you need to know, and you're quite conceivable to get kind of an acute kidney injury station where you have to stop the medications, and then you're told, oh, this patient's got these U&Es, what would you do now, kind of thing, and you'd have to go through that. And it's something you see quite often. Right, this I threw in because I find it really difficult to get my head around, and it's just basically recognition. So just recognise the patterns. So forget about bloody Marrow and William, because I tried to learn them and they just don't work. Just remember what it looks like. So right bundle branch plate, you get these two R's, so you get two positive deflections and only one negative deflection. Compared to the normal V1, it's quite obvious what it is. And left bundle branch block just goes as a negative deflection. So if you just have to ingrain them into your memory. If you Google it, you can get that same slide up, and it will go up on the Countdown to Finals website. But they're just things that you just need to sear into your memory so that you can spot them. The reason I put this up for you lot is because we had a case of this in work a couple of weeks ago, and I couldn't spot it. I was just like, what? Because you're never bloody looking for it. So just sear them into your memory. Anaphylaxis. So the station giveaway here will be that you've been asked to go and see a 57-year-old gentleman who's come in with an exacerbation of COPD, and you've started him on antibiotics, has had his second dose and has got a bit short of breath. What's going on? That sort of thing. So what are your cardinal kind of symptoms? Shout them out. Go on. Let's kill rash, yeah. Wheeze, shortness of breath, angioedema, they're all your barn door things. Generally, the ones that the nurses will call you for are the shortness of breath. They don't notice rashes. So if you go to the patient and they're short of breath and they've got a rash and you listen to the chest and they've got wheeze, you need to get on with it. So yeah, symptoms. What investigations would you do? Review the drug chart. Yeah, that's the sensible answer. Investigation-wise, if you think it's anaphylaxis, you don't do any investigations because you haven't got enough time. You would potentially do a tryptase or send one off, but that's not your immediate concern. Investigations is look to see what they've had, what could they be having an anaphylactic reaction to, and things like medications, gelifusing, even blood, and all those things are things you need to be thinking about. And if they've had anything that you think could have caused an anaphylaxis reaction, what do? Stop it. Yeah, that's the first thing you got to do, and that's the easiest thing to miss. We can all treat anaphylaxis really well because there's a pro forma for it, but make sure you stop the culprit because it's just going to carry on. So the first thing you do, if you think it's anaphylaxis, stop whatever's going in, because you can always restart it, but just stop it first and allow yourself to reassess. How would you treat it? Say again. Adrenaline, what? Shout. How would you give it? That was a bit mixed. Someone did. How would you give it? Yeah. So we had have any of you been to the safe simulation in either Bradford or LGI? They have the mannequin things that talk to you and flash blue lights and things. We had a safe simulation day a month ago, and this anaphylaxis station, just like the one I've described to you, came up and you had to manage it. And one of my colleagues gave IV adrenaline, which in this circumstance would kill the patient. So just get it right. Thankfully it was a scenario and it wasn't in reality, because it would have been a problem. But yeah, oxygen, adrenaline, chlorphenamine 10 milligrams IV and hydrocortisone 200 milligrams IV. They won't get you out of the acute problem, so if you haven't got them, don't worry about them too much. But remember them, obviously, it's the adrenaline that is going to make the difference. And you're not going to do any harm if you listen to the chest and think, well, it's bilateral wheeziness, maybe this is an acute exacerbation of asthma. You're not going to do any harm by giving them 5 milligrams of salbutamol nebulizer as well. So when I did this safe anaphylaxis station practice, I listened to bilateral wheezy. There was a nurse there, so I asked them to start the nebulizer, and then I carried on. The patient didn't have a wristband on, so I was thinking this could be anaphylaxis, but I was only going on the fact that I'd have a second dose, and so I just gambled and went through it and gave the adrenaline and got everything else, and it worked out all right. But that's where your clinical judgment comes up. You're not going to get anything that hard in your OSCE. It'll be barn door. So check the drug chart, check the allergy chart on the top of the drug chart, and wristbands to see if they've got a red wristband on. If you're in the OSCE or on the ward, where can you get all this stuff really quickly? Yeah. So a lot of it. So some of the F1s I was doing this safe simulation wondered why I'd asked for the crash trolley when I thought it was anaphylaxis, and it's because it's in a box. So if you go for the anaphylaxis box, you can't get mixed up with IV or IM adrenaline, because it's the only one that's in the anaphylaxis box, and it's that. All right. Next one, acute respiratory failure. You've got away with the symptoms here. What types are they? Type 1, type 2, what the difference is? Yeah. What makes that a different treatment regime? Yeah. So, although I think I had an argument with one of the clinical educators in Leeds about this, and because it was type 2 respiratory failure, and I basically said I'd put them on oxygen immediately, 15 litres first. I still think that's the right thing to do, because hypoxia will kill them before hyperkapnia kills them. In your OSCE, I'd probably be a little bit less gung-ho about it and tread carefully and say I'd stick them on 15 litres of oxygen, but I'd want to do an ABG just to check we're not in type 2 respiratory failure, and then I'd titrate their oxygen down accordingly, or I'd leave it where they are. because that's you can't be wrong with that sort of answer. So as long as you kind of quantify it, fine. And why do you think you're doing a chest X-ray? Yeah, so you want to know what could be causing it. What causes type 1 respiratory failure? Say again? Pneumonia, yeah. Asthma, PE, yeah. Type 2? Yeah, it's always COPD. You can always get things like muscular dystrophy and the weird and wonderful things that basically don't mean they can't clear their oxygen, but it'll always be COPD. And these are in separated because you kind of get the agitation cyanosis is with hypoxic, and sleepy hyperemic is due to high CO2, so type 2. And then so these are the kind of the phrases. So for type 1, it's variable performance device, oxygen delivery devices are fine. You can stick them on anything, just basically get the PO2 up as high as you can, within normal limits obviously. And then the catchphrase for type 2 is the fixed performance devices, so you know exactly how much oxygen you're giving, so that then if they do become hypercapnic, you can just titrate it down and there's less variability. So that's the kind of the phrases for either of those. DKA. Symptoms? Yeah. Yeah. Sure. Yeah. What's up? Confusion? Yeah, you can get confusion. What are things? Say again? Vomiting? Yeah. You can also get your typical diabetic symptoms, so your polyuria, polydipsia, and all those sorts of things. And tachypnea, which is your cut smells, and reduced consciousness if it's all getting a bit out of hand. Investigations, blood glucose, yeah, and urine dip. So DKA in those symptoms, unless you kind of get 5 of them, and even to say, even if you've got kind of dehydration, vomiting, abdominal pain, tachypnea, it's still a difficult diagnosis to make because you're still a bit wacky with kind of the collection of symptoms. So my advice is, particularly when you're working, is if you're going to see the sick patient, get a blood glucose and get a urine dip, because it then just rules it out and you don't have to worry about it, especially in diabetic patients and especially in patients that you're not sure where you're quite going with it and they're young, because it could be the first presentation. It's just easier to do. It takes the nurse like 5 minutes and you rule it out, or you've got your diagnosis. So yeah, that's what's important. ABG is the big one. Because that'll dictate how aggressive you need to be, but also where you need to escalate. So if they're massively acidotic when you see them, you need to be getting on the phone to ICU, because they're going to need something a little bit quicker than you can do. And then what are the kind of the fundamentals of treatment? We're not going to go into particulars. Fluids and insulin, yeah. And every hospital has their own pro forma for it. In Leeds, if you haven't got the Leeds Teaching Hospital pro forma, I would advise just having a quick look at it, because it's something that could come up. And if you'd seen the form before, you'd get it in your OSCE. It's just going to make you a bit more slicker at filling it out quickly. And the Leeds ones are quite good. You just need to make sure you've got the right one with Leeds, because there's like A to E or F of possible options. So just check that. And then the chest X-ray, the ECG, and the blood cultures. Why are they important? Yeah, so you're looking for the trigger. So often with DKA, there's been something that's put them into it, and it's often infection and other things. So you just want to rule those out. And just fluid replacement and insulin. You could get bogged down in what it is, but it's just easier to look at the pro forma. Upper GI bleed. Symptoms? Hematemesis, melena, cough of ground vomiting, barn door, epigastric pain. It's all pretty straightforward. The two that I would mention that you need to look out for, especially in like an OSCE station, if you're just looking for a bit of a heads up: alcohol excess. Why is that important? Varices, they also are at a greater risk of getting things like esophagitis and gastritis, but the varices is the one you want to rule out. And medications, NSAIDs, don't forget aspirin is an NSAID as well, because that can cause upper GI bleeds. It's a lot rarer now that we're using ibuprofen and diclofenac, but aspirin can still cause upper GI bleeds. Investigations? Full blood count. Say again? Come on, reel them off. So you want your full blood count, you want your urinary electrolytes. Why is that important? Yeah, but what you're looking for that might confirm this diagnosis? High urea, yeah. So if you've got a drop in HB and you've got a raised urea, you've got your diagnosis. You also want to know what their electrolytes are doing, things like that. You want to group and save and cross match them, and you want to do things like clotting, because especially if they're alcoholics, their INR will be off to the pot because the liver's knackered. And so although you might be feeding them full of blood, if their INR is still 8, they're going to keep bleeding, so you need to correct that. How would you correct an INR of 8? Vitamin K, yes, and you give 20 milligrams IV if you're worried about it. Full blood count, using ease, clotting, cross match, ECG, chest X-ray, and that's the treatment it's the investigation and the treatment. If you're in your OSCE, you mention the Blatchford score, because that indicates who needs to go for immediate OGD and who needs it within 24 hours. Basically, if it's an upper GI bleed and they're hemodynamically stable, they need an OGD within 24 hours. If they're hemodynamically unstable, what do? You just resuscitate them, yeah. So you fill them full of fluid, you get as much blood in them as you possibly can, you whack 2 massive cannulas in them, and you hope you're not the only doctor around, because you're going to get covered. And there's been one patient that's come into Bradford when I was in gastroenterology, and she basically was having esophageal varices and was vomiting up litres, and it was also coming out of her back passage. She has no recollection of the situation, but honestly it was like a murder scene in MAU. It was horrific. You'll never forget it. And one of the regs was talking to me that this isn't an actual sign, but if you ever meet a registrar called Dr. Hutchinson, he has a sign which is the Hutchinson's positive sign, and it's basically when you have anybody who's too polite just to kind of vomit, so they cover their mouths to stop them vomiting, but you then get the blood coming through the nose like a fire-breathing dragon. And this lady was doing that, and it was horrific. She actually did all right, but she went for immediate OGD after I think we gave her equivalent of 12 litres of fluid and 4 units of blood, and she got banded and was all right. But it's messy. Yeah, that we gave terlipressin. I don't think that's something it'd be a bonus mark in your OSCE, but yeah, we were. I didn't, but in this. And I was not alone. So in this situation, if you're on the phone and you're like calling a senior, and you get, I would happily have written it up on the drugs chart and given it, yes. But I would have always spoken to my registrar first. This lady had the registrar down, had the on-call endoscopist down, and the on-call surgeon, because they were thinking we might not be able to control this kind of thing. So you'd consider it, and if you're on the phone to them and they say give it, you'd give it. And if it's varicose, you'd also cover them with prophylactic antibiotics. But don't get bogged down in that too much. The resuscitation is the most important thing, and that's bonus marks if you're aware of those. PUO. What is it? Yeah, what would you do? Well, actually, that's not. Well, it's not. What are the symptoms? So you've got pyrexia and you don't know where the hell it's coming from. So you can have loads of stuff, but the pyrexia is the big one. Headache, nausea, vomit and diarrhea, restlessness, fatigue, pain. It's one that can come up in your OSCE as a history and as mainly as a history, and it's a bit of a wishy-washy history taken. You don't really know what's going on. You've basically just got to do your sepsis 6 or your Buffalo. It's the same sort of thing. It's just screening for everything. If your Buffalo and everything comes back negative, what investigation may you consider then? You go for an LP. And inflammatory markers, that's just like a CRP, and the only real reason you do that is because you're going to start them on antibiotics anyway if they're sick, but you need a baseline CRP to kind of give you an indication of whether your empirical antibiotics are working or not. So it's not going to help you in the diagnosis process. If you've got a pyrexia that's up, or a pyrexia that you don't know where it's coming from, it just gives you an idea of whether you're actually doing anything or not. So that's pretty straightforward. But start antibiotics, that's the main thing. So, good question. It depends where you'd hedge your bets. So, if you're hedging your bets that, say they've had, I don't know, they've had a recent knee arthroscopy, what do you think you'd start them on? I would guess. Yeah, so you go flucloxacillin, benzyl penicillin. If they've come in and they've got a load of abdominal pain, what you might start them on? Kef and Met, yeah. Have you all seen the prescription of Kef and Met that has actually wrote CEFNMET? Yeah, don't write that because they won't know what the hell you're talking about. But yeah, Kef and Met for intra-abdominal. If you're thinking meningitis, you go for something like ceftriaxone. So you basically you'll have an indication where you think it might be. Otherwise, if you really don't have a clue, if you go for something like tazocin and ticaplanin, you'll cover almost anything. So that's known as the domestos, so you just clear out anything. PE, again, symptoms. Yeah, it's all pretty straightforward. It's kind of split up into three. So hypertension, tachycardia. If the hypertensive, tachycardia, and the hypoxic, that's kind of a massive PE. They're probably post-op, and they've got a big one like a saddle embolism or something. You start treatment straight away. The shortness of breath and hypoxia is kind of the multiple kind of small things, and then the pleurisy and hematemesis is kind of they've got something that's actually gone the distance, an infarcted part of the lung. So that's a small emboli, but it's not the kind of smallest. So that's why you get kind of classifications of the sort of symptoms. The important investigations, ABG. What do you think about D-dimers? Yeah, they're crap, but you do it because if it's negative, you know it's not a PE. But then generally, if you're thinking it's a PE, and particularly if you've got hypertension and tachycardia, you're not going to fuck around with a D-dimer. You're going to treat it, and you're going to ask for the CTPA, and do the Wells score because it ticks a box. In Bradford, you have a whole pro forma that you go through, and you've got to get an ultrasound of the lower limbs, and you've got to get a D-dimer before you can get a CTPA. It's a load of rubbish. If you really need it and you really think it's a CTPA, just speak straight to the radiologist or whatever, and you'll be able to get them through. Obviously, you need to speak to your seniors. You wouldn't be just doing that on your own little hunch. Yes. Yeah. Based on symptoms and clinical suspicion, and that probably wouldn't be your call as an F1, but yeah, you treat and then wait for the CTPA to be negative. If it's negative, you stop, or you go back to your prophylaxis. Important thing there is the arterial blood gas. Why is that? What you're looking for on that? It's pretty straight. Yeah, basically how hypoxic are they? How much oxygenation do they need? If you're giving them 100% oxygen and they're still only of PaO2 of something like, I don't know, 78%, you probably need to be phoning ICU as well, because they're going to need something more, because they're probably going to need thrombolysis. But that's, again, a decision you wouldn't have to make. Yeah, so I think in Leeds they use Clexane, so that's basically 1.5 milligrams per kilogram once a day. In ACS, it's 1 milligram per kilogram BD, so they're quite easy to remember. But ACS is the bigger dose, but Clexane's just a bigger single dose. And then thrombolysis is something that you would need to be aware of because you need to consider it, but it's a decision that you won't make. And then long-term warfarin, or an equivalent of one of the new rivaroxabans or whatever, there's something that you might manage. So on our PE station for our OSCE, you got a mark for saying that we then need to probably start them on long-term warfarin at least for 12 months, and a DVT is 6 months. What's this? Yeah, don't even look at the ECG. It's leads 1, it's leads 3, it's S1Q3, T3. Pneumonia, so symptoms, cough, productive, yeah, pyrexia. You can get loads of other stuff. New onset AF is commonly caused by a pneumonia as well, and so you need to be aware of that, because they might be a little bit arsey and just say, oh, you look at this ECG, it's AF, what kind of things. They might be to do a respiratory examination, which might be off the wall. You're not going to have someone who's acutely unwell with a pneumonia, but that's probably where they want you to kind of go with things. Investigations. chest x-ray, sputum samples. Yeah. What bloods do you need? Full blood count. Why is that important? Yeah. So, curve 65. They basically, do you all know it? Do you all know which antibiotics you go to? Fine. So you know that because if you get a case of pneumonia and you come up, so you do an AMTS for the confusion, you do a urea, I think it's greater than 7, your respiratory rate is above 30 and blood pressure less than like 90 systolic, and then 65, and it basically dictates which antibiotics you'd start, whether they need admitting to the ward, or they can just be followed up by the GP. It's all pretty straightforward. They're just the doses. So it's basically just amoxicillin as your first. You then add in clarithromycin, and then if it's greater than 3 or above, it's coamoxiclav and clarithromycin, and that covers everything. What might you use if you're thinking pneumonia, but they've got a background of COPD? What else may you throw in or use instead of? Doxycycline, yeah, and that basically just covers the atypicals. So severe hyperkalaemia we've been through. Asymptomatic can be often an incidental finding. So the most common things you find this out is when you've got a sick patient, you do an ABG on them, you look at their potassium and it's through the roof, or you're just chasing bloods on an evening, which is a ball ache because you get to like 4:30 in the day and you get someone's potassium that comes back as like 6.2, and you've got to go and do an ECG and start treatment. You can't not do it. So ECG and ABG. So the reason I've mentioned ABG there is because you want to know what the potassium is at that point of you doing it. It's also the way you monitor it quicker than getting the bloods back from the lab, which you'll be doing daily. But you don't have to do ABGs, so you can do VBGs, and they'll still give you the potassium back, and they cause less grief for the patient. We've been through those. The one to be aware of that I didn't really appreciate when I was a fifth year is calcium gluconate actually wears off. So if you've got somebody that you're not managing to actually lower their potassium with the dextrose, although you probably need to be thinking about dialysis to get that potassium down, you need to be re-administering the calcium gluconate because that's what protects the heart. So don't forget about it. I can't remember off the top of my head what sort of duration of action it actually has, but it's just something to be aware of, that if it's going on for a couple of hours, you're probably going to need to give them another shot of it. What's this? Complete heart block, yeah, spot on. So you've got, it's just asynchronous. You've got regular PUAs, regular QRSs, but they're not matched. What's this? Yeah, honestly, remember it. Any questions on anything? No? All feeling happy? Brilliant. Okay, if any of you are in Leeds or going off elsewhere but would like to be involved with Countdown to Finals next year, drop me an email and I'll lodge your interest. It'll probably be when you're doing shadowing that I get round to actually putting out applications, things for people. But there are now Countdown to Finals programs running in Birmingham and one in London, and I think in Hull, York. So if you are interested in getting involved, give me a shout and I'll see what we can do. Leeds, there's often a number of people that are interested, so there is like a competitive application, but it's pretty straightforward. Good luck. I'm sure you'll be fine.